So I'm very pleased to welcome my colleague, Dr. Hélène Rousseau of the Department of Family Medicine, who is one of our laureates for this year, to the Academy of Exemplary Physicians. So welcome, Hélène, if I may call you that.
Thank you very much.
I'm delighted to meet you under these wonderful circumstances. Maybe we should start by giving you a chance to tell our viewers and listeners something about the path that led you to where you are now, the work you're doing now, a family physician, involved in so many activities. It'd be interesting to hear because nobody's path is ever linear. So the stories are always interesting. So if you don't mind, we'd love to hear yours.
Perfect. I'll start with that. And actually, it's interesting you mention it that way because I find that when I'm teaching students and residents, I always say, but what's the story behind this person?
Right.
And so we all have different stories. Born from French parents in Canada, moved to Ontario, moved to the States, came back here, did some nursing studies, and all of a sudden was accepted in medical school. Was it a career plan that I had envisioned? Maybe, but it wasn't a linear path.
Right.
Definitely not.
Right.
And having traveled all over, lived in different provinces or countries, certainly brought my perspective. You know, you have a more open horizon, not just living in one neighborhood for your whole your time, moving, changing friends. And I had a passion starting from the first year of medical school to say, I'm going to be a family doctor doing obstetrics.
Wow.
And
right
amazing.
From the beginning.
Right from the beginning. And 30 years into practice, I'm still doing that.
Wow.
With a passion. But through the career and through that path, I think I had many opportunities to gain other experiences. And sometimes when we're offered challenges, we sort of shy away from them a little bit.
Sure.
Because it's time, it's work. It gets us out of our zone of comfort.
Yes.
That's we need to recognize it. So the challenges that we have to meet are sometimes professional and sometimes personal. I think each and every one of us have personal challenges, which, interestingly enough, we often don't talk about.
Right.
Because, and it's okay, they build up who we become.
Okay.
Slowly they're integrated into what we do, into how we react to situation, how we interact with other people. And so life's challenges brought me to start my practice in Châteauguay, where I practiced for 8 years. And then I had the opportunity to come and join a teaching unit here in Montreal. And that's where I think it was really amazing how I was integrated into a team of new colleagues, but I became one of them.
Wow.
So despite being a Montreal University grad, I became part of the McGill family with the people I was working with, I think, were able to spot where I could excel.
Okay.
Because often we don't know how we're going to perform in certain circumstances. We go to school, we learn as medical students, we learn as residents, we know we can see a patient in emerge, we know we can see a patient in the office, but we have so many other talents, so many other capacities that unless we're given a chance to do them, unless someone pushes us to do it, we never develop these abilities.
That's really interesting. So how did your work and your appreciation of work change when you moved from Châteauguay into a teaching unit? You said people offered you opportunities or pushed you towards opportunities. So can you tell us about some of those and how they made daily work different for you?
So I think one of the the opportunities that came about are that being in a teaching unit, your work is not limited to clinical activities.
Okay.
So when you work outside and you have an office, you have to see your patients, you have to do your hospital work, but you're not challenged with teaching, with academic activities, besides the teaching, with some administration. Yes, I did in Châteauguay, but not so much. Mm-hmm. And so relatively quickly in the Côte-des-Neiges area where I work, I started being chief of medical activities where I was. Okay. And quickly I was pushed into a role of being the rural director for McGill, for family medicine, but also for all the specialties. And from there, it evolved into a position where there were a lot of responsibilities. So I became assistant dean of rural education, which was a challenge, something I would never even have thought that I would get there. And as you become involved in other activities, working at the Department of Family Medicine, because I spoke Spanish, one of my colleagues say, well, we have an opportunity for a project in Ecuador.
Wow.
So that's how we've been running a project in Ecuador for 12 years.
And you're still part of that?
It's still running, although I can say that as funding goes down, but I'm still involved with the communities. Other opportunities that came about was that one of the person responsible for undergrad at the Department of Family Medicine had contacts with international organizations. So because I was fluent in French and English, I was invited to go and teach in Rwanda.
Okay.
The courses in advanced intervention in obstetrics.
Oh, boy. Right.
And then I was invited to go and teach in Haiti. And the earthquake came about.
And you were there.
I wasn't there when it happened. My plane ticket was booked. But then we switched it with contacts from another one of our leaders, Dr. Jimenez. We were in contact, and we actually went and did 3 weeks of humanitarian work in the camps. And so that's how it comes about. Opportunities come, and the first thing you could say is, well, no, I have to see my patients. I have my calls. I can't do them. And then you say, well, why not?
Why not, right?
Why not?
So you do. So with that amazing combination, tell us what a day of work is like for you. And I imagine they might be different day to day. So is there a typical day that gives the students and colleagues listening what a day of work means to you, what it is?
So there is no typical day. And I think that's what actually helps with our passion, because when you're doing just one thing, you become fatigued. So when if you're just seeing patients all the time, at some point you're like, I don't want to hear another patient complaining about his back pain. Okay? If you're only teaching, you're like, I don't want to prepare another course. So it's the mixture of activities that makes it sustainable, and that just keeps that light, it keeps the fire going, so you want to keep going. So typically I have full days of clinic, but I work with an amazing team of nurses. So we've actually specialized in taking charge of pregnant women who arrive often from other countries, or who have sometimes mental health issues, or in contexts of really vulnerable populations, so who arrive and who haven't had prenatal care. So we take them on often in the last month of pregnancy. We have to arrange. They come with nothing. And we've built up with a team of nurses, and also at the Maison Bleue where I work. It's a community center where we have social workers and nurses, midwives. So it's that interdisciplinary work to really reach out to women. No one else wants to see them. You're too advanced. sorry, but she needs someone to see her, and she's going to deliver the baby no matter what.
Right.
Then I have days where I'm doing supervision in family medicine, so doing the walk-in clinics or the residents have their clinics, and I'm supervising, so it's direct clinical supervision and teaching. I have days at the Maison Bleue.
Right, for obstetrics.
For obstetrics and follow-up after.
Right, right. Are you still able, and is it possible in today's environment, to be a family physician in the old sense of looking after families? Is that something that you are still able to do in your mode of practice? Or is that something that is an aspiration that's hard to do these days?
It's hard to do these days, especially when you do obstetrics.
Okay.
Because the problem when you do obstetrics is that your practice widens. Every time a woman delivers, there's an extra patient to your practice.
Got it, right.
And if you want to keep practicing obstetrics,
Right,
the patients from 30 years ago are not having babies anymore.
right.
So you're having new ones coming in.
Okay.
And so in obstetrics, it's difficult. Some colleagues still do it. However, when we talk about burnout in physicians, it's often because we have a patient load, and because of the lack of physicians around, we are asked, well, could you just see my father-in-law? Could you just see my sister? And so the practice grows to a point where it's not sustainable. Mm-hmm. And then the more you try to do, the less people are happy with you. Right. Because they can't get appointments with you.
Right.
And so that state of burnout that we talk about is there. And I think it's recognizing it for ourselves and recognizing it for our colleagues.
For others, you mean, right?
Right, because our younger colleagues, they have that aspiration of we'll save the world.
That's right.
And then you realize, well, yes, but I need to take care of myself.
Sure.
Also to be able to do it.
Right. So you also do something, again, which is probably not common now, which is a family physician in an urban setting doing a large volume of obstetrical care. That's a choice you made, obviously, because you were interested in it, or
yes,
it meant something important for you vis-a-vis the patient. How did that come about?
How did it come about? I don't know. There's a passion. There's something very special about deliveries, about the births. And interestingly enough, family doctors who do obstetrics will often say, if I wasn't doing obstetrics, I would be doing palliative care.
Really?
Because in medicine, there is the technical aspect, there is the academic aspect, but there's also a spiritual aspect.
Yes.
There is an aspect of something being sacred, which doesn't mean religious necessarily.
Right.
But there's something happening that's beyond what we can explain.
Okay.
In books. There's a feeling, there's a presence, so you can be a technician or you can be there and just let the moment happen, accompany, just say, for a birth as for a death. Something is happening. Right. You are there to accompany the people who are going through it, and you bring your medical expertise to intervene and facilitate that process. But you are not, I hate when people say, oh, you delivered a baby. I said, no, I help the woman deliver. And the same thing when someone's dying.
Sure.
Unless you're doing the aide médicale à mourir where you're actually stopping it, you're actually facilitating the process of what's happening.
And so you see, for both obstetrics, especially as a family physician, and palliative care, as having a spiritual dimension.
But the spiritual dimension is not limited
Okay.
to these. I think the spiritual dimension accompanies a lot of accompanies most people. A lot of people, some people will write out, say that they have a religion, that they're practicing. But for many others, it's surprising how when you open the possibility of another dimension about not the work that we're doing. Yes, it's work that we've learned in the books, but it's also, we can call it our intuition, the little voice inside of us. A colleague of mine says, my nose tells me there's something.
Right.
So it's also feeling something else.
Right.
Which is difficult to explain.
You use a very interesting word. You use the word presence, right? Being present. You're describing the physician's role as being present to the moment. Is that what you have in mind?
Exactly.
Right.
And I think that when we're seeing patients on a daily basis, we can gain a lot from listening to what they have to say.
Sure.
It's proven that doctors interrupt patients after less than 30 seconds, but also to all the nonverbal cues.
Yes.
And it's something that we teach when we're in family medicine. We have the opportunity of watching our learners sometimes,
Yes, of course.
not all the time. But the learner that's on the computer and doesn't watch the patient is missing out on cues. And often in clinic, we will pick up on very subtle cues that something's not going well.
Okay. How do you learn and how do you teach your trainees, residents, or medical students to not interrupt in less than 30 seconds? How do you transmit that lesson when they may be enculturated to the computer and a very rapid pace of what they call now patient flow? How do you learn and how do you transmit that notion?
So patient flow and time management, they're being taught.
Right.
It often is through, when we have the opportunity, which we don't always have, of watching them directly.
Right.
We will pick up that, like a very easy example is the patient, they're taking an obstetrical history.
Yes.
And the patient will mention either that she lost one of her parents or that she lost she lost a baby or had a miscarriage. And the resident just jumps to the next question.
Wow. Okay.
And I'm saying, losing a parent could be difficult. You could have just paused and say, oh, that may have been difficult. Just pausing to, sometimes we do it by role modeling. So we happen to be in the room and something comes up and we just stop.
Yes.
And showing the person who's there that it doesn't necessarily take that much more time.
Right.
It doesn't need to be a 15-minute.
Right.
Just the pause and recognizing is important.
So you offer them a little silence, right?
Right.
To allow things to happen. Earlier on, you used an interesting word when seeing patients. You always said, what's the story here? Like, what's the narrative behind what you're hearing? Tell us more about that. When you say the narrative behind, what are you describing?
So, yes, it's a man, it's a woman, it's a child that has a certain age. But where do they come from? Who do they live with? What kind of work do they do? Even in a walk-in setting where we have very little time, it's a question I'll often ask the resident. What kind of work do they do? Because that right away tells me an awful lot about the person behind. Where they come from it just opens up many hypotheses about what's going on. Okay? Especially when I'm reviewing a case, I don't necessarily have the patient in front of me.
Okay.
So when you have a patient in front of you, you can see what is the color of the skin. Are they short? Are they obese? Do they look happy? Do they look sad? These are all subtle cues that I think with time, It's part of our interventions to look at these cues.
Right.
They may not be picked up by the learner, and they may not be communicated to us.
Right.
If you take a patient who's from Haiti, but who's got 3 children, let's say, and who had a birth in Chile or Argentina, then I say, oh, so are her 3 children with her? And the answer will be, well, I guess so. And I said, no. The 2 born in Haiti probably stayed behind. She went to get some work in South America, and then she came up the road of death. La voie de la mort. And a lot of people, like some people, don't even know about it. That road that some of the refugee claimants go through, and that we only see the ones who survive, actually.
Of course, right. So knowing that gives you another insight into that person.
Absolutely.
And to that person as a patient as well.
Yes.
And gives you cues that or clues that you need to know.
It gives us clues, and also in the clues, sometimes it's don't disturb too much the background of that person. Interestingly enough, we had a journalist who came and met some of our refugee patients at the Maison Bleue, and she wrote in her article, they're very discreet. They don't talk a lot.
Interesting.
Because it's so difficult and so personal and sometimes so awful what they've gone through that they're just trying to put it aside for a little bit so that they can try to have a new life here.
Okay.
Eventually, they may be able to open up, but not every trauma, not every life experience needs to be brought into the open.
Okay. So you allow them to choose what they wish to open up to.
Exactly.
And to divulge.
Don't push onto a closed door because you may do more damage.
But you still give them an opportunity to make the choice.
Absolutely.
As to wish to open or not.
Yes.
So what joy, if it is joy, I hope it is, do you get from teaching? It sounds like that's an important element of what makes your work fun, to use that word.
It's sowing seeds. That's the beauty of it. I think the beauty of our teaching units is that every teacher is different.
Okay.
And I often reflect that to learners. You're here, and Dr. X may be telling you to do it this way. Dr. Y may tell you to do it this way. And it's the right thing to do. You have to be exposed to different ways of approaching a different problem.
Okay.
So that you develop a critical sense, a critical approach where you can bring options to a patient and find what is best for that person and how you need to practice. So some patients want a doctor who's very straight and who tells them, you do this, 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 and that.
Okay.
Other patients want to be offered options and see what else can I do. And if you're critical about the medical literature, yes, there are things that we must do, but there are also a lot of gray zones. And teaching the gray zones to the residents will allow them to become who they want to be.
Okay.
And every doctor is different, and it's good because the patients some want doctors who are more open to discussing the options, while others want...
Right. So do you find yourself customizing your approach to those different patients, their different needs? Sometimes you're more cut and dried, this is what we're going to do. And other times you're more a navigator and a partner. How do you find out what that person needs? And then how do you adapt your behavior to those needs?
So I think it's not so much tailoring it to the patient, but often to the condition.
Okay.
So when there's something that really you need to intervene because there's a risk,
okay,
then it's amazing because when I do deliveries, sometimes the patients tell me after, your voice changed, and I knew I didn't have a choice but to push.
Oh, isn't that interesting?
So they picked up in my voice that I was worried. And because often I offer the choices, saying, well, here are the benefits, here are the risks, you decide what you want. But when I say, now you, they pick up that I'm worried.
Right.
And it's based on the knowledge that we have.
Sure.
It's being able to pick out what is really dangerous.
Right.
And what do we offer because
There are choices.
Because it's good for you and it's... And so it's teaching the residents also
How to do that.
how to do that. Like this kind of condition is serious and there could be consequences to delaying the treatment or not taking it.
Right.
Whereas for a lot of other treatments, yes, they're recommended, but the benefits may not be as good
Right.
as we thought. You know, think about some screening for cancers.
Sure.
At first, it was screen for everything because it's the best.
Right.
And now it's, well, each person has to decide.
Right. Right. And make choices.
Exactly.
Tell me what constitutes a good day at work when you say you go home and, or you, in your case, I guess you bicycle home, right?
Right.
And what constitutes a day when you get home and you say, I'm tired, but I had a wonderful day?
I think if we're able to identify times where we actually changed something, where we were able to do an intervention that could have potentially saved life, whether it be medically or psychologically,
Sure.
helping someone get out of a difficult situation, when we're challenged and we picked up a difficult diagnosis, but we're like, ooh, I'm happy I didn't drop that one
Right.
because it would have had consequences. And it could, you know, so when we feel we're making a difference.
Right.
So as an opposite, if you're doing walk-in and you're seeing people who come because they're coughing and they don't have a fever for 24 hours and you're like, okay, but.
Right. Sometimes students will say, I had a difficult patient. And do you ever hear that word? And how do you deal with it? Because you deal with so many different kinds of patients, sometimes in other languages. Sometimes, as you said, they arrive and a month later they're going to be giving birth. So these are unusual circumstances. So what kind of language do you use that helps you cope with that variety of challenges that you see?
Right. So I think there were two questions. The part of when the residency students have a difficult patient,
Right.
the first part is identifying why is it a difficult patient for you? Is it because there are a lot of medical issues? Is it because there's a language barrier?
Right.
Is it because this patient has mental health issues and it's difficult for you to relate to
Right.
that? So I think first, and the same actually applies when I was assistant dean and I was visiting the rural areas.
Right.
I had the supervisors would tell me, you know, we would teach about the difficult resident or the difficult student.
Okay.
And it's exactly the same thing. Why is it difficult? Do I start off having a judgment on this person, which because I'm defensive, why is this patient so obese? Like, why aren't they controlling their diabetes?
Right.
Why aren't they taking their medication? That comes and gets me. And often the medical students and the residents expect the patients to follow their treatment plans.
Right.
They expect them to stop smoking. They expect them to lose weight. They expect them to...
Sure.
And I'm not even touching on patients with mental health issues.
Of course.
Okay, so as soon as you touch patients who have, you know, personality disorders, it becomes even more challenging.
Right.
So identifying why is it difficult? Is it me? Is it the patient?
Right.
Is it the situation? Is it because I don't have enough time today? Is it because there are too many health issues that I have to deal with at the same time? Mm-hmm. And then taking the reason of the frustration and saying, how can I fix that?
Okay.
Do I need to give another appointment? Do I need to book an interpreter? Do I need to look for something to help me? Do I need to review my expectations?
Okay. That's interesting.
Lower the expectations that I have for this patient.
Right. Okay.
And say, maybe the best thing I can do for this patient is be present for him or her.
Right.
And accompany them with what they're going through.
Right.
Knowing that I won't necessarily bring them to where I would want to be.
Of course. So it's some kind of tolerance, right?
Exactly.
And for that person. So that's an interesting approach because, in a sense, you don't only say, what's the story behind this patient, but what's the meaning behind this word, right? So you unpack the single word that the student uses and say, let's understand what's going on here, right? So each one becomes a little clinical puzzle that you have to figure out. You mentioned earlier the notion of you have a nose for something or the intuition about something. And you again connected that to a spiritual, not in the religious sense, but a sense of something else going on. And you see a connection between those, right? The sense of intuition. And where does that come from?
I wish I knew. I think we each have other senses. We always talk about our five senses, but each person can pick up often on other things.
Sure.
We often don't talk about it. It's not recognized. And we don't each have the same capacity to pick up on these things.
True.
And so if I'm picking up on things, I can't necessarily expect someone else to be able to pick them up.
Right.
But maybe I have guides.
Right. So maybe, and did you think or did you see or feel that grew with experience? I imagine it did.
It grows if you accept it
Okay.
and if you let it grow. So if you accept to be guided, saying, that little voice, come on, I've got other patients to see.
Right.
No, go check that, go check.
Okay.
So if you accept to listen to it, if you accept to follow through,
Yes.
then I think, you said what makes you feel that like you have a good day is when you're saying, all right, tough luck. I'm going to be late. I'm going to be behind in my clinic.
Yep.
But that particular thing bugged me.
Right.
And I'm glad I took the time to stop and look at it. And I find that as you were talking earlier, when we're talking about we're pressured to see patients.
Sure.
Your time management and everything. And sometimes I hate when I'm late in my clinic. I hate when patients are waiting in the waiting room. But occasionally that little voice says, careful.
Okay.
There's something going on. And I find that if I stop, most of the time I will identify something.
Right. So usually that little voice is correct in what it's telling you.
Right. So it is correct, acknowledging that it's there and thanking it for guiding me.
Right. You also, besides all the other things you do, you had an administrative role for rural education. And so you met a lot of practitioners in rural settings who were taking on students and residents from our school. And what were they like, and what made those physicians add another chore to their daily work by taking a student? What drove them to do it, or what motivated them to do it, and how did they react to the opportunity?
Well, I think first, extremely dedicated, because sometimes it's extra work. It's time to invest. What also drove them, I think, is to share their passion for what they're doing, because we're very lucky to be able to, as residents, as students, I had the opportunity to go outside of big centers and learn how things are done in lower resource settings. Okay, when students come to us, well, he's got abdominal pain, so he needs a CT scan, and I'm like, wait a minute. I may have to teach him. If I teach that at the CLC Côte des Neiges, that's good, but the CT is just across the street.
Yes.
When you're up north, are you going to call a plane to do the CT? So I find that they bring to the teaching something that's very enriching, very eye-opening. They help to train the doctors of Quebec because, let's face it, we have, our territory is so huge that we need doctors who are able to work rurally. And the only way that we're going to attract doctors to work there is by exposing them to the challenges, but the joys of rural medicine.
And do people describe it to you as a joy when you talk to your colleagues in rural sites?
The joys of working there, or the joys of yes, because they wouldn't stay there otherwise. Right. Our system here in Quebec is like, yes, you may have to go there for a couple of years, but you can come back. Why do they stay there so long? And I've actually worked in rural setting as a dépanneur, doing locums for many, many years, doing obstetrics and very remote centers. And it's a different practice.
Yes. And a different kind of joy.
Yes.
From being here. One of the other things in your remarkable career is doing administrative work, not only for the faculty, but for the Collège des Médecins. Is that something that you do as an obligation or because you enjoy the work with other kinds of colleagues? How does that fit into a very busy...
Again, it was opportunities that were offered, and I continued doing them because with time and the more work we've done, the more experience we have.
Yes.
And we have a choice of sharing that experience or saying, well, I'm just going to do my little thing. But I find that it helps the collège, to have someone with experience in rural training, who's been abroad, who's worked in, Châteauguay was more community.
Sure.
Montreal is very urban, doing rural. So you can bring experiences, having done the three of them, that help the college is a big organism, and they're open. They're serving all of the doctors in Quebec.
Sure, of course.
But often they don't hear so much from people who are outside of the big centers.
I get it.
So it's bringing an expertise that's really, that they want.
And they need.
So they make you feel appreciated when you bring that in, because you don't just bring in your narrow vision of what you've done here.
And you bring in what you've done everywhere.
Exactly.
That helps them. What changes do you see, if any? Everyone talks about artificial intelligence and computers and electronic records, and that medicine will change dramatically. What's your sense? What do you see in the kind of work you do, which is a huge variety of medicine? Do you see changes that you will welcome? Do you see changes that concern you? And just as importantly, what kind of changes would you like to see in your own day-to-day work? How would you like to see it evolve?
Okay, so there are a lot of aspects to that question.
Sure.
One of the things with the electronic medical record is if we can get one that integrates all of the parts, that's certainly going to make our job easier.
Yes.
Because just one day when I'm in the hospital, I may have to open 4 or 5 applications.
For one patient.
With different passwords. So that's
That's not good.
If that can all be integrated, that for sure is going to help us.
Yes.
We need to see that in medicine, there's a part that's really important. That's the human contact.
Yes.
And there's no machine that's going to replace it.
Okay.
Whether you speak English or French, you have a state of well-being and you have a state of unwell-being.
Yes.
And every person has a different way of expressing when they're not well.
Mm-hmm.
And I'm not sure machine is able to sort it out.
Okay.
It can be very cultural.
Mm-hmm.
Interestingly, in some languages, if we ask our translators to use the word depression, the word doesn't exist.
Oh, okay.
Because it's just not something that's recognized. So the unwellness may manifest with undifferentiated physical symptoms.
Mm-hmm.
But unless you put the person in the context, I'm not sure a machine would be able to sort it out.
Okay.
The machine may not see the facial expression. It may not integrate where the person is from. It may not understand what is behind. And patients don't necessarily open up in the same way, whether it be an individual, a machine,
Yes.
a computer. We each have parts of our lives that we keep secret, and so do patients. And sometimes we need them to open up to get the key to the problem. One of the typical examples is women who present with chronic abdominal pain.
Mm-hmm.
And often they will have gone to the emergency room, they will have had scans, they will have had laparoscopies,
Right.
sometimes surgeries. And one time I told the resident, did you ever ask your patient if she had sexual abuse in the past? Now, it's not a question that you can just ask to any patient who presents with abdominal pain. And I forgot about the patient. And 3 months later, the resident comes up to me and says, you know, that patient with abdominal pain that we discussed? And my first thought was, what did I miss? And she said, I asked her about sexual abuse when I saw her the next time. And she just broke down in front of me. But it takes time. It takes to establish a relationship. And part of the teaching that we do is sometimes, how do we actually ask the question?
Yes.
Because you don't look at someone in the eye and say, have you ever been abused? Like, the person isn't going to answer you. So it's bringing it about. You know, sometimes it's saying, you know, we've done a lot of tests in patients like you who suffer from abdominal pain. Some of them have been abused in the past. And sometimes you don't even go.
Don't go further, right?
You don't even go further. And sometimes you won't get the answer in that visit. It may take 1 or 2 visits before the patient will actually say, you know, what you told me about, I've thought about it, and
Guess what? Yeah.
guess what?
So you see then to each patient a kind of coherence. There's a story that has to fit together somehow. And a machine can't do that, right?
I don't think so.
Okay. But you mentioned human dimensions, and one of them is connecting with the patient. What are the other elements or those dimensions that are important in the clinical engagement, in the clinical interactions? Well,
taking the symptoms seriously when the patient comes to see. So it's a mixture of everything. It's showing that you're truly listening to them, that you're truly recognizing that they're suffering.
Right.
It's having access to the tests and the imagery that you need.
Sure.
If you need, okay? Because the clinical, just the human dimension isn't enough.
Right.
But it's working with all of the elements together, not just going, oh, it's just in her head, or no, it's just a physical. And sometimes the residents will tend to say, well, first I'm going to rule out the physical causes, then I'll move on
Yes.
to the next part. And it's like, no.
Right.
You may need to start integrating
Right.
both. And often I will tell, we talk about wellness, we talk about being an unwellness.
Yes. Mm-hmm. And so you don't like to split that this is the physical and this is the psychological and this needs a test. You see a more coherence amongst all the elements.
Because I don't think you can separate them.
Right.
And even someone who has a physical problem, if you tell a patient that he or she has a cancer or that they need a surgery or that there's something serious, there is still a psychological dimension to the disease that you cannot, breaking the news to a patient that they have diabetes is not just about monitoring their blood sugar.
That's right.
And getting it under control. It's about all the changes they have to make in their lives. It's the fact that they have to recognize that they have a chronic disease.
Sure.
Okay, so if you start by, if right at the beginning you integrate both, you're going to have a lot more buy-in from the patient who's not just going to leave you with.
Right. So one of the questions that we talked a little bit about is, where would you like to see your own work go over the next number of years? Are you interested in more teaching, or there's never a shortage of clinical work, that's for sure.
That's for sure. I'm not sure I would take on more clinical work.
Okay.
Because at some point when the clinical work is very demanding,
Yes.
you run out of empathy. As I was saying, there's just so much that one person can deal with.
Right.
You can do a lot more interventions, like wholesome interventions, dealing with the psychological, social aspects
Right.
when you're in a good team.
Okay.
And I think at this point in my practice, I'm working with solid teams, which means that when I have patients with many issues that are difficult to deal with, I'm not alone. I'm not carrying that weight alone, because that will get someone into burnout.
You can't. So what does the team look like, Hélène? Who are the members of that team?
Well, at the CLSC, we have the nice thing with the GMFs, the Groupe de Médecins de Famille, is that we have nurses, so clinicians. We have some nurse practitioners who work with us. We have a nutritionist. We have a pharmacist.
Okay.
We're hoping to get maybe a physiotherapist on board. And we have social workers.
Right.
So having different individuals helps us so much, because instead of being stuck with, okay, but if I add this medication for this patient, what's going to be the impact? Because they already have a list of 10 medications. And the pharmacist answers me saying, well, try this one. The other ones may interact. Makes my job so much. Like I'm not pulling my hair out saying, what am I going to do with my diabetic patient who's not controlled and who's got this essential tremor that I need to treat.
Right.
Makes the whole difference. And then at the Maison Bleue for the pregnant woman in context of vulnerabilities, we have educators, social workers, midwives.
And they help counsel the women both before and after delivery, right?
Exactly.
To look after a newborn.
Right, and children. At the Maison Bleue, it's up to 5 years. So...
And they follow up to the age of 5?
Yes.
The children? Wow.
Because when you talk about women in context of, psychosocial vulnerability, there are also issues with development of the children that are not stimulated enough, that are, lack of education. In Africa, we say it takes a village to raise a child.
Of course.
And when they come here, sometimes they're single parents. Sometimes they have a partner, but who doesn't know anything about children. They don't have their families.
There's no large family.
There's no large family to guide them.
Right.
So that's where we build a village around these
that
patients.
woman and her child.
Exactly.
And her children. Is there something else that I haven't asked you that you would like to tell us about?
Well, I think for anybody who's working in the field, don't miss out on opportunities to go beyond. Okay? Yes, working in your own little practice and maximizing your time and seeing patients and can make you lead a very comfortable life. But accepting the challenges that lives bring about is just so exciting. It just opens up new doors. It makes you see things differently. And it actually allows you to have a better interaction with your patients.
Right.
Because it widens your horizon. You're not just looking into one direction. So that's for the ones who are working in medicine. And for the teachers is the students and the residents, they want to learn.
Yes.
Some of them may not be as open as we think. But it's amazing how, as I was saying earlier, you sow some seeds and you don't know which ones, where they're going to grow.
Right.
But there's nothing like having a doctor coming back to you a few years after they've been in practice saying, you know what, I had to do this and I thought about you.
Wow.
I knew I was going to be able to do it.
See, that's a lovely compliment, right, to a teacher.
It's amazing.
Yeah.
And often, why does it happen? Because I put the residents out of their zone of comfort.
Right.
When a woman is delivering, I'm not delivering her, right?
Right.
I often don't break the bed. I let her take the position she wants to do the delivery. And the residents are like, oh, but I'm not comfortable. And I looked at them and I say, you won't be doing obstetrics later, right? So the one that you may have to deliver may be in the back of the car or in a wheelchair. So if you've seen it like this, you'll be able to do it.
Okay.
And that's where I've had physicians coming back. I was in a dispensary and I didn't know what to do. And then I said, oh, I've done it with Dr. Rousseau. I can do it.
Wow. Thank you for those lovely stories. And thank you for showing us what a wonderful role model is. So thank you for taking the time and congratulations on this wonderful honor.
Thank you very much.
Great to spend the time with you.
Very appreciated.